Good evening, everyone. Respected Dr. Shaili Mehta's ma'am, members of IATP, and dear doctors. We welcome you back for another episode, Learn from Our Master series, organized by IATPE. And yes, crossing 50 webinars is definitely an amazing journey so far. And I thank all doctors who are attending our webinars and other platforms like our Instagram and Facebook pages as well. We are very humbled to see your positive feedback. For those who are attending our webinars for the first time today, we will give a brief introduction. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes of dentists of all disciplines and abilities. Our organization is established based on the fact that dentistry is complex and require ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professional and guide their dental journey. So, without further ado, let us start our series episode in which our topic of discussion is desensitizing composite restoration, given by Dr. Shaili Mehta ma'am. Dr. Shaili Mehta is an endodontist and she is the youngest fellow of Style Italiano Endodontics from India. Dr. Shaili ma'am has got IACDE Clinical Excellence Award in 2024 as well as IES Endo Case Contest 2024. Dr. Shaili Mehta ma'am is the proprietor of Dental Dream Academy in Navi Mumbai. I would like to invite Dr. Shaili ma'am for today's discussion.
Hey guys, so just give me another 5 minutes and I will be ready with my presentation. Just give me 5 minutes. Hey guys, so is the screen visible? Is the screen visible? Fine. Okay, so extremely sorry for the delay. Now, as Doctor has already introduced me, I am Dr. Shaili Mehta. I did my BDS from a college named as MGM. That's in Navi Mumbai. I did my post graduation from GDC Mumbai, and then I went ahead and completed my I was an assistant professor at GDC Mumbai. Then I now am a private practitioner in Navi Mumbai and a proprietor of the Dental Dream Academy. Now, without much delay, let's talk about composite restoration. Now, what is the first thing that comes to your mind when I say composite restoration? Now, I feel that most of the participants here are doctors, and they have been practicing. I mean, doctors, as in they have been practicing for quite some time. So, there are two clinical situations. Whenever you examine a patient for the first time, so there are chances that you might see a restoration that looks something like this, where you have micro leakage, there is gap leakage, and then there is secondary decay, everything. This is a common thing that we see in patients' mouth. Now, if you are a practitioner who've been practicing for more than 5 years, you will see your own restorations coming to you like this after 3 to 4 years. So now, why is this myth? And I'm very sure that in colleges, and I'm sure that some or the other person has told you in life that, composite is not good. Go for amalgam. Amalgam is better because of its self sealing properties, because of its strength and everything, because it does not require as much isolation as composite does. But right now we are in a modern era where composite is the most important material we have, because most of the countries are now banning amalgam. So we don't have an option between of choosing between amalgam and composite. It is composite. Now, if it is composite, we have to make sure that it lasts as good as amalgam. Now, the thing is, in dental colleges, amalgam, whenever it's taught, it's been taught to us in last 4 years. Like whenever you start your BDS, right from that time till your final year BDS, you've been taught only dental amalgam, because of which you have a proper methodology engraved in your brain. And when it comes to composite, most of the colleges in our country give you composites when you are in internship. Very rarely people give it to you again in your final year. But when you talk about final year, you've already wasted 3 years of dentistry. That's why whenever we do composite, it's all haywire. So when I say composite dentistry, it has to be peaceful and mindful dentistry. The same way you have a proper protocol, your convenience form, your convergence, line angles, point angles, everything in amalgam, you apply your base, then you apply amalgam. Everything is there in your muscle memory. Now, what you need to do, just excuse. Hi, I'm unable to share my screen. Can you please switch it on?
अरे हम एक पुनः खरीदे आपका एक पुनः
Sherry ma'am, actually, it's not audible. Video is being there, but the audio is not there, ma'am.
You can see my video. You can see the screen.
For now, I can't see the screen, but you're audible.
Okay. Now,
Yes, doctor. Now it is.
okay. So I was talking about peaceful and mindful dentistry. Now, amalgam has been engraved in us. It's been in our muscle memory. So what we need to do is have the same muscle memory for composite. And the only way of that is going to happen is that you start practicing your composite restorations. If you are new at composite restoration, start writing down steps. Because we have given so many exams on amalgam, we have a very good memory, and you are thorough with amalgam, but the same thing is not true for composite. So we need to follow a stepwise protocol for our composite restorations. Now, what are the common problems we have in posterior composite restoration? There are different challenges in anterior, different challenges in posterior. Now, the first important thing that we have is post-operative sensitivity. Second is marginal discoloration. And third is, of course, secondary decay. Now, this all are related to only one thing, which is just a simple thing that we've all actually read and written in our exams, that is polymerization shrinkage. Whenever you say composite restoration, polymerization shrinkage is something like a free package. It's a buy one get one free offer, something like that. That's why everyone is scared of composite restoration. Now, apart from just getting marks in exams, today let's understand what this polymerization shrinkage actually means. Now, when I say polymerization shrinkage, this term itself, obviously, we understand it's shrinkage of composite, because of which we have sensitivity, marginal decay, discoloration, and decay. Now, the most common problem and why everyone is scared of in composite dentistry is post-operative sensitivity. Now, what does sensitivity mean? Is it a fact or a fiction? So, the fiction is all composite restoration cause some amount of post-operative sensitivity. But the fact is, it is multifactorial and can be minimized or eliminated. Now, let's talk about the tips and tricks for our composite restoration through which we can minimize the sensitivity. Now, as I said, we need a peaceful, mindful dentistry in when we are doing composite. So the only thing we can achieve that is through a proper protocol. Now, this protocol, what I'm going to do discuss today, is specifically related to preventing post-operative sensitivity and making your composite restorations last long. So the first thing is we have pre-operative protocols, intraoperative, and the last is of course post-operative protocols. Now, when I say pre-operative protocols, so the first thing, whenever we do composite restoration, everyone has told us isolation, isolation, isolation. So this is what we do. We put n number of cotton rolls, suction everything in the patient's mouth. And the moment you move to take your etchant or your bonding agent, this is what the patient does. Your entire isolation has gone for a toss. So a simple pre-operative requisite for composite restoration is rubber dam. Now, this rubber dam could be a single tooth isolation. If you're doing a restoration, it has to be a multiple tooth isolation. Now, rubber dam is a topic where we can again discuss for 1 hour. So, I've just discussed a very short part of it. Now, imagine this case. Here, it was impossible for me to do this case without isolation, because here it's a maxillary tooth, so I'm not very bothered about saliva. What bothers me here is going to be my gingival clavicular fluid, the GCF, that's going to leak from the second molar and contaminate my restoration. Apart from that, it is such a deep restoration that I can have blood from the gingiva coming anytime into my restoration. So for such cases, rubber dam is not an option, it's a compulsory thing. Second, whenever we do composite restoration, everything is haywire. So if you are working in college, we are used to working this way. You go, you take etchant, you go, you take bonding agent, then you go ahead and take composite. Most of the colleges work like that. There's a specific section, you go again and again and take that. But meanwhile, your isolation's gone for a toss. So whenever you are practicing composite restoration, you need to make a proper list. make a checklist. If you're doing a class 1, make a proper checklist. If you're doing a class 2, make a proper checklist. So in that case, you are just avoiding unnecessary chaos. So these are the two the post pre-operative thing. Let's now talk about the actual crux of the topic, that is the intraoperative procedures. Now, the first thing is caries excavation. Whenever we see a patient with DK, this is the first thing we do: rubber dam isolation, and we take a burr and drill right into the center of the tooth. This is how we excavate caries, and this is how we've been taught. But take a step back. We are doing composite dentistry. Every one of us know enamel bonds better than dentine. So why not have a good peripheral seal area and then move towards the center? So why not excavate caries from the side and then move towards the center of the tooth? Just by this change, we are achieving a great peripheral seal. And this method of caries excavation is called as centripetal caries excavation. Now, once you are done with this step, the next step comes is your caries detector dye. Now, human eye is not capable of recognizing affected and infected dentine. We need a chemical agent for that. And that's where your caries detection dye is going to help. So apply your caries detection dye, rinse it for 30 seconds, and once you are done, you will see some spots. Now, these are your infected dentine, affected dentine, and superficial enamel. What this denotes is your peripheral seal zone, which is going to give me the strongest bond, which is going to prevent my post-operative sensitivity. Then the next zone is going to be caries removal endpoint, and the third is going to be central stop zone. Now, once I'm done with caries excavation, the next step is obviously we start with our composite restoration. So this is my restoration that's in dentine. We apply our etchant. Next thing we apply is our bonding agent. Now, I'll tell about a term which you have all heard in our childhood. That is our second year BDS. It's called as hybrid layer. But let's now today understand what is this hybrid layer. We've all written 3-4 line definitions on hybrid layer. Let's today understand what it means. So what exactly happens after etching? Once you have etched your enamel and dentine, you have your micropores. Once you apply your dentine bonding agent, in those micropores, your dentine bonding agent seeps in. The bonding between these pores and your bonding agent is your hybrid layer. So this red area, after application of bonding agent, once you cure it, then it becomes a hybrid layer. Simple, as simple as it could get. So enamel causes pores. The pores are filled up with dentine bonding agent, and that is basically your hybrid layer. Next step is we apply composite, we cure it. Now let's understand what exactly happens when you apply a big chunk of composite on top of your hybrid layer. So this is my composite. I've zoomed it up. Now I've cured it. Now initially it was believed that the composite shrinks towards the source of light, but it is not true so. They later found that composite always shrinks towards the center of mass. So this is how the composite is going to shrink. And now this force is so tremendous that it breaks the hybrid layer. It is so tremendous that it shrinks, but along with its shrinkage, it also breaks the hybrid layer and pulls the hybrid layer away. So this is how the composite looks. Now, obviously, you're not going to stop here. You apply your second layer of composite. Again, you've applied a large layer, you cure it. And now, after curing, there is even more force on the hybrid layer. So, even this hybrid layer breaks. Now, as a rule in body does not like empty spaces. So, the only way of filling this empty space is through only one fluid that we have inside the tooth, which is dentinal fluid. So dentinal fluid comes and fills up this area. And we all know by the definition of sensitivity that rapid movement of dentinal fluid to and fro is what causes sensitivity. So this is the time after 28 to 48 hours when you get a call from your patient, doc, I am having sensitivity. दांत में झंझनाहट हो रही है. This is exactly what happens. Now let's understand what exactly happens after this. So the body has filled up a cavity, but the patient is having pain. There is a lot of pressure in this dentinal fluid. Now again, by nature, does not our body does not like areas which are enclosed. So when you have abscess or when you have any pus filled cavity, it tries to burst. So here also the body is going to try to eliminate this pressure created from dentinal fluid, and there's only one way that the pressure can get released is from the sides. So once the pressure is released, the patient feels that the pain has gone. So whenever the patient calls you after 1 2 days that I'm having sensitivity, what is your common reply? Okay, yeah, fine, wait for 1 to 2 weeks. After that the sensitivity will go. This is how it goes. Now the pain is gone, sensitivity is gone, you are happy, patient is happy. But now understand what has happened. There is now a exchange of fluids between your dentine and your oral saliva, which has the maximum number of bacteria. So because of this, there is secondary decay. Now this is a case that came to us. He gave a typical history that this filling was done 2 years back. He had sensitivity for 10 days. After that he was fine, he never had a problem. Right now he's having extreme pain on not pain but sensitivity on hot and cold. Why is this happening again? So his concern, he himself was a dentist, his concern was it's because of the small decay that's there on the distal side. But when we look closely, even the mesial restorations look suspicious. So we went ahead, removed both of the restorations and realized mesial was a bigger culprit. This is what has happened. Because of secondary decay, there is a larger cavity now on the mesial side. So why does this happen? There is something called as hierarchy of bondability. Now we all have understood this, that enamel bonds best. Then we have superficial dentine, there's deep dentine, and radicular dentine is the worst to bond to. Now hierarchy of bonding is the problem. Okay. Now we've all understood the difference between enamel and dentine bonding, but let's just simplify and understand the crux. I'm not here to teach any theoretical stuff. I'm going to give you real life examples. Now dentine, considered it to be as your fevicol and enamel as your feviquick. Whenever you apply feviquick, you just take it, apply it, and it sticks. It's immediate action. But when you have fevicol, if you see in any carpenter use this, they apply it on a sheet of plywood, they let it rest for 3 to 5 minutes, then they stick it to the wood. So your dentine needs time to mature. This analogy is by Dr. Disha Agarwal, and it's an amazing analogy to understand the bonding. Now we spoke about the problem, that is hierarchy of bonding. Now let's understand the solution. The first solution to this is immediate dentine sealing, and second is decoupling with time. Now, as I said, we have dentinal moving fluid moving up and down. The only solution is that immediately after you have insulted your dentine and pulp with your burr, irrespective of how deep the cavity is, you always insult the pulp a little bit. So once you have done that, apply a very thick layer of bonding agent. Now this was suggested by Pascal Magnet. This is immediate dentine sealing. What they suggested was OptiBond FL, because it has a filler content of 70%. So because the filler content is 70%, it automatically creates a very thick layer on dentine. Now once this is done, we cure it. Now, the only problem in this entire statement is that OptiBond FL is still not available in India. So, what is the solution? The other alternative was given again by Pascal Magnet. We can use any universal bonding agent, apply it in thin layer. Since the filler content is less, we have to apply a very thin layer of flowable composite as well. So, we etch, then we apply a very thin layer, so etch as in selective etch. Okay, so if you have to apply immediate dentine sealing, the etching step is gone. So you have taken my burr, I've prepared a cavity, the cavity is very deep. I apply a universal bonding agent which is acidic. So it indirectly etches the dentine. So I apply my universal bonding agent in a very thin layer, then I cure it and then apply my flowable composite. The second thing, what you can do is decoupling with time. So as I said, everyone understood what hybrid layer was. Now we have to let the hybrid layer mature. And ideally, what is suggested is that you apply your dentine bonding agent and your flowable composite and wait for at least 3 to 5 minutes. If you wait for 3 to 5 minutes, your dentine bonds to your tooth, and your dentine bonding agent bonds to your tooth, and your hybrid layer is very strong. So, after this, if you apply your composite and cure it, composite will try to pull it inside it will try to break the hybrid layer, but hybrid layer is now mature enough to not break. So, again, you have a proper peripheral seal. So that is what decoupling with time means. So we have a deep cavity, you apply a very thin layer of universal bonding agent, cure it, apply a layer of flowable composite, cure it. After that, we have, of course, incremental building of composite. Now, if you have a very deep cavity or you have one or two walls missing, you can use fiber reinforced composite. Now, these are small fibers. It again, if you relate it to practical scenario, it's similar to having your iron rods in between concrete. Concrete itself in a building construction is strong enough. But when you put your iron rod, it becomes stronger. So fiber reinforced composite works in the similar manner. So the fibers that can be used are these rebond fibers that are easily available nowadays. So this is how a fiber reinforced composite looks like. So this is the intraoperative procedure. We started with caries excavation, then we move ahead with actually how to create a mature hybrid layer and how to have our immediate dentine sealing. The last thing is the post-operative protocol. Now, there's a term called as oxygen inhibition layer. Now, we all know that for amalgam to bond to the next layer of amalgam, we need excess mercury. So, two layers of amalgam bond because of excess mercury. Now, ever wonder how does one layer of composite bond to another layer of composite? It's because of free radicals. So when I have one layer of composite, it has free radicals. So these free radicals are highly reactive and they are going to react to the free radicals in the successive layer. So this is what happens in composite dentistry. Now this is okay till the topmost layer. Now in the topmost layer, the layer that's on the top has free radicals. Now it is highly reactive, so it is going to bind to air, water, it's going to bind to all the spices in the Indian food, it's going to bind to probably anything the patient's going to eat. Even it's going to bind the dust particles that are going to get accumulated during finishing and polishing. So if you have realized after you finish and polish, if you created grooves on posterior composite and the dust or the excess gets stuck there, it's because of this. It's because of these oxygen free, because of this radicals which are highly reactive, it's gonna get stuck to anything. Now to prevent this, we need to apply a very thin layer of water soluble material, something like you can use either your glycerine or KY jelly. KY jelly is easily available in stores. If you can't get it, you can apply a layer of Vaseline and then cure it. So what happens is you have the oxygen in the topmost layer as bonded to something that is not going to damage the restoration. Okay. So what does this include? Our stress-free dentistry comes only with the protocol. So we have our pre-operative protocol, we have a rubber dam, then we have a checklist, make a proper checklist of what exactly materials you need. Then intraoperative, you have caries excavation, immediate dentine sealing, and decoupling with time. Post-operative, you have to apply a layer of KY jelly on top of your restoration, and last part is finishing and polishing. Now, when I say posterior composite, this is the most ignored part, finishing and polishing. Now, let's discuss why. So this is best explained through clinical cases. So this case we've already started discussing. So we have a centripetal excavation. Then this is our peripheral seal zone. This is where I applied my universal bonding agent because it also has acidic properties. I haven't used etchant yet. So I apply my universal bonding agent, I cure it, I apply a very, very thin layer of flowable composite, and then again I cure it. Then I wait for 5 minutes. After waiting for 5 minutes, I take my fibers. Now, this technique is called as fiber wallpapering. So I've literally used fibers as a wallpaper on both my walls. Again, I cure it. And on top of this, I again apply a very thin layer of flowable composite because if I put plaquable composite on top of fibers, there's going to be void. So I apply flowable composite, and always remember flowable composite is the weakest composite we have, irrespective of the company. So use it in as minimum quantity as possible. Then we go ahead with now selective etching and then incremental buildup. So that's it. That's how the composite is. If I leave the patient like this right now, patient is going to come back after 2 days with a yellow restoration, a completely yellow restoration. Now, why does this happen? Is because first thing is I have not applied glycerine or KY jelly. Second thing is finishing and polishing. Now, usually this is what people say: posterior composite does not need for finishing and polishing. But tell me one thing: composite is a material. It's the same syringe. You are using the same syringe for anterior composite, for posterior composite. So how does the composite know whether it's been placed on an anterior tooth or a posterior tooth? It's not like that. You have to polish irrespective of the location. So this is my sequence of finishing and polishing. I always start with a disc, give a primary anatomy, then I have some kind of polisher. So I usually use either 3M, that is Flowflex, or I use EV Twist, that's by Ivoclear. So I use it, polisher, pre-polisher. This is a Super Buff by Shofu, and this is how the restoration is supposed to look. Okay, always check the occlusion, because what happens is whenever we do a beautiful restoration and check the occlusion, this is what exactly happens, and we don't want that. This comes only with experience. If you want to avoid this, simple tip: take a articulating paper before you start excavating caries. The patient has come to you, you know you have to do a restoration. Take a articulating paper, place it in the patient's mouth, ask the patient to bite, record the points, record the areas where the tooth is in contact. Remember it, take a photo of it, and then go ahead with your restoration. You will never have a high point there. Now, second case. Now, in composite dentistry, as I said, it has to be a peaceful and mindful dentistry. Now, in this case, this was a very young patient. So, this kid was around 20 or 19 years old, but look at the fracture pattern. Now, the problem here is not that the amalgam has fractured. He has, at this young age, he has a mesial facet on the mesiobuccal cusp. Now, at 18, 19, you don't obviously expect a tooth to have a facet. I checked the opposing tooth, it had a plunging cusp. So, it's not necessary that every time you give, deep grooves and cusp and everything. Sometimes you have to look at the occlusion, the pre-operative occlusion, and then decide. So, in this case, there's a there's a video which is for some reason not playing. Okay. Anyway, this is the third case. Again, the same protocol. So even for class 2, it's going to be the same. This is the case we already discussed. Each step is a point of evaluation. Then class 2, now a simple tip for class 2: whenever you have class 2 restorations, always convert your class 2s into class 1. Your life would be much simpler. Because coming from an amalgam era, we always try to restore class 2 in the end. But even in amalgam, they say always condense the amalgam against the matrix band first. So same thing, you can convert your class 2 into class 1, get rid of the matrix band, because nowadays we're using sectional matrix band. Even TOEFL Meyer, if you're using, it is so huge that it kind of makes everything clumsy there. So convert your class 2s into class 1, remove your matrix band, everything. Now peacefully do your class 1 restoration. And another tip, always, always, always after your class 2 restoration, just take a IOPA. Bite wing is the best. If you don't have a bite wing or you don't know how to take a bite wing, take a normal radiograph. Just check if your contours and contacts are proper, if you have a actual marginal seal. If you don't, then trust me, at this stage, even if I take a IOPA right now, I have still have these butterflies in my stomach that I don't know if there's a void, I don't know if it's a proper seal or not. So, and if you're a beginner, just start taking from tomorrow onwards, just start taking IOPA. You will realize many mistakes in your class 2s. So always, as a tip, just if you're doing class 2, it cannot be without IOPA. This was another doctor that I treated multiple class 2s. Now, this case is a very interesting case which shows that in which cases selective etching and which cases your complete etch. Now, there was a so there was multiple caries here. As you could see that on 6, it was deep. So I followed the protocol. First, I applied universal bonding agent. I applied flowable composite, waited for 5 minutes. Then I started with selective etching. And on the other teeth where the restorations was shallow, I went ahead with full total edge. If you ask me which is better, total edge or full edge, sorry, total edge or selective edge, always, always, always total edge. But your dentine does not like total edge. So if you have a very deep restoration, that's the time you will go for your selective edge. Then I went ahead. Now here I did a little staining. I don't do that anymore. If anyone is interested in staining, this is the stain I used for this case. Again, composite restoration documented stepwise. So we've cleared all the challenges. The first one was post-operative sensitivity, second was marginal discoloration, and third is secondary decay. This all is just because of polymerization shrinkage. If you follow these protocols, you are going to avoid all three. So by implementing these pre, post, and intraoperative strategies, we can effectively manage and minimize post-operative sensitivity after composite restorations and ensure long-term survival of the composite restoration. Now, whatever I have spoken in the past 45 minutes, there's no alternative. You can't replace rubber dam with your cotton rolls. You can't replace your universal bonding agent maybe with a fifth generation bonding agent. You cannot replace flowable composite with packable composite. You cannot replace your fibers with something else. You cannot replace your caries detection dye. So the reason I'm telling you is these are the common questions people ask. If I don't have a universal bonding agent, can I use something else? No, you can't, because you're not etching here. So you need a universal bonding agent which has a acidic property within itself, so you don't, so it compensates. It does not 100% compensates for your etching. Etching is done with 37% phosphoric acid, which is a very strong agent. Your universal bonding agent does not etch so much. But to prevent sensitivity and have a good prognosis of the dentine, this is what the model protocol is right now. So I'm open to taking questions, and you can reach out to me and follow me on Instagram. You can just scan this and you can follow me on Instagram. Thank you so much for your patient listening, and extreme apologies from my side for the initial delay in the lecture.
Thank you, Doctor. Thank you so much for sharing your expertise and knowledge. So, as we are moving towards the end of the session, participants, if any queries regarding the topic, please share it through the chat box. Doctor, like few questions are put up already, so I'll just read it for you. One of the participants have asked, why does sensitivity occurs after composite restoration?
I think that was the entire session we spoke about. That's because of polymerization shrinkage, and explained in the session that how it exactly happens. So you have your exchange of dentinal fluids because you have a gap. There is a space, and your dentinal fluids are getting exchanged. So that's why you have your sensitivity.
Thank you, doctor. One other question is, should we air dry after bonding agent?
So what I do is basically when you air dry it, there are chances that some minute water particles are going from your three-way. So what I do is I use two applicator tips or even three sometimes. So I one applicator tip is one with the bonding agent. I apply it, I scrub it for 20 seconds. I use another fresh applicator tip, again scrub it, and then if needed, I use the third applicator tip. You can air blow if you are 100% sure. So usually nowadays there are two three-way syringes in one chair. So what you can do is the doctor side, obviously you can keep the water supply on, but the assistant side three-way that you have, you can switch off the water supply so you are very sure that the water is not coming out. If in case the water is coming from your three-way syringe and you are air blowing it, you are actually contaminating the composite, the bonding agent.
Thank you, doctor. The question is, should we apply bonding agent over enamel after selective etching of the specific area?
Yes, you have to, because you've etched. You cannot skip the bonding step. So you have to in selective etching also selective etch, then bonding agent, and then your composite restoration.
Uh, can we use dical or calcium hydroxide or even GIC as base layer in deep caries?
Okay, so this is a very initial concept. Even in my UG, my undergraduation days, this was taught to us that whenever you have deep cavity, apply dical, then apply GIC, and then composite. Now, today, modern dentistry and modern materials are moving towards monoblock concept. Even in root canal, why are we using bioceramic sealers? Because we need a monoblock concept. We need one surface. We don't want multiple surface. So when you're using calcium hydroxide, GIC, and then composite, you have literally three interfaces. The more interfaces you have, there are more chances of micro leakage in the future. None of these materials have a tendency to bind to each other. Your dical does not bind to your GIC, GIC does not bind to composite. So why not have a monoblock of composite where each layer is bonding to the other one? That's the recent concept now. So we are not using dical anymore.
Thank you, doctor. Can we apply Gluma desensitizer in deep cavities before applying composite?
So, if you look at the literature, there have been some studies that state that all these desensitizing agent kind of affect the bond strength. So, I personally do not. Of course, there have been studies that also suggest that it does not. But then I am a very lazy person. So, my point of doing a composite restoration is to reduce the number of steps. So, if I can again have a monoblock only with my universal bonding agent, which I'm anyways going to use, if I use my sensitizing agent, desensitizing agent, again I have to edge bond and everything is going to be the same. So if I can save up on an extra step, I would prefer to do that. So that's why you can apply. It's not a thing where I'm saying it's you can't, but then studies have suggested that it affects a little bit on the bond strength. It has some effect, so I avoid it.
What kind of sectional matrix that would be recommended for daily composite restorations?
No single composite restoration is done with no single system is enough. So you have sometimes you have to use your Toffel-Mayer, sometimes you have to use your Garrison, sometimes you have to use your Palodent. Every system is different. You have your BioClear. When you have a very broad contact or you have to create literally like a contact like this which is super convex, then BioClear is the best. If you want to have mediocre contour, then your normal matrix band is okay. Your Garrison, or I use Dual Force. The photos that you all saw was Dual Force. Okay, that's in India. It's sold by a company called as Dentex. So if you go on my Instagram, you will find a link to their page as well. You can see my cases. They are in there in the collaboration. So and sometimes if you have multiple broken walls, you have a ring matrix by Garrison or your simple Sasta Sundar Tikka or your Toffel also. So a lot of things I've seen where especially in postgraduates, that the moment they are done with the final year, they throw away their Toffel Mayas. It's not like that. Your Toffel is going to be helpful even in your composite dentistry, not as frequently as your amalgam restoration, but again, it is going to be important for your composite as well. So don't just throw away any material. So it's literally like, I can't give you a guideline key for this case. You have to use this. You have to look at the case. You have to see which gives you the best contour and then decide. So no single system is enough.
Thank you, doctor. What is the post-operative instruction that could be given to the patient after composite restoration and their life of a restoration?
Nothing, just don't eat for an hour. That's it. Because that's also because of the anesthesia and stuff like that. But apart from that, no restoration. Rest everything is up to you. Earlier, people used to call patient for finishing and polishing after 24 hours. But now with the modern material, it's not even required. You can finish and polish in the same appointment. And once you, I have seen doctors telling, especially after anterior restoration, don't eat haldi, don't eat chili or turmeric. You might get discolored, but it's getting discolored because of your fault. Patient can't resist Indian. All Indian foods have turmeric. All Indian foods have chili. How can you ask the patient to not eat such stuff? And if the patient is even avoiding these stuff, there's air, there is water, there is other food stuff that we are eating, there are dust particles. So if you follow these two things of post-operative finishing and polishing and your oxygen inhibition layer, you don't have to give any other instructions to the patient.
Any other substitute for dical lining in composite filling? And also one more question is that can we use MTA putty as the base?
For, see, my point is that if you have a pulpal exposure, don't use dical, use MTA putty. That's the best thing you can. But apart from that, as a regular concept, don't use MT at all. I mean, it's not required. If you have a deep caries, use this concept. Trust me. I mean, it's not my concept. It's been used by Dr. Alman, David Alman. So it's a very old concept. It's been time tested. I've used in my cases, so I don't think there's a problem. I've not faced any problem as such. MTA only use when you actually have a pulpal exposure. Yeah, of course, if you have a pulpal exposure and don't put denting bonding agent, it's gonna react horribly.
What is the brand name for the universal bonding agent?
You can, all
Universe.
companies have it. So by 3M, you have single bond, then you have by one code by Colteen. So literally every company has a universal bonding agent. Ivoclair, but yeah, of course, go for standard companies. Go for 3M, Ivoclair, Colteen. All these are standard companies. Don't buy cheap bonding agents. Are there any more questions?
Is endocrown susceptible for secondary caries?
Sorry, endo?
Endocrown susceptible for secondary caries?
Endocrown, you gain excess from the chamber and it's already root canal treated. So I didn't get the question. I mean, I think it's not even recommend, I mean, it's not even related to the topic.
What is a bar suggestion option for finishing and polishing?
Never use burrs. Your top layer of composite has to be so smooth they can, you can directly use your disc. Always use your disc and don't complicate your life. A lot of people use aerotors and burrs and all this, that no. Your composite has to be supposed to, you use such instrument. You can use Optra Sculpt, which is what I use. So it makes your composite very smooth. Optra Sculpt is an instrument by Ivoclair. It is a silicone pad which is attached to an instrument and you just place it. It gives a very smooth surface. So once you're done with this, you can directly start with your disc. And after you're done with your disc, you can use your pre-polisher and polisher. Just three things. That's it. Don't complicate your life.
How to remove smear layer if dentin is not etched?
we are scrubbing our dentine bonding agent, and we are using a universal bonding agent, which is having a property of dissolving the smear layer. There are three types of bonding agent. One where you are total etching, so you're removing this. If you're using a universal bonding agent, it's actually dissolving the smear layer or partially removing it.
Thank you, Doctor. I think we'll wind up the session for the day.
Okay.
Thank you so much for sharing your knowledge, and the PPT was very informative.
Thank you so much. Okay.
Thanks
Thank
to
you
all
so much
doctors.
Thank you so much for giving me this opportunity. And if you all want to learn more about composite dentistry, you can follow me on Instagram. The handle name is Dr. Shaili Mehta, and I would be happy to help you. Even if you have some doubts, you can ask me on your on the messenger, and we can just have a talk.
Yeah, thank you, ma'am. Thank you. Thanks to all doctors for
Thank you. Bye bye. Good night.
And your participation for this webinar. And I hope everyone, all you will depart the session with positive, confident manner. Once again, thank you, Dr. Shaili ma'am. It was a wonderful session, and we really appreciate your valuable time given to us for this series episode. Please check out Dr. Shaili Mehta ma'am's Instagram page, where you can appreciate her clinical works and do ask queries regarding. And to know more about our upcoming webinars and workshop, please do check out our website, that is iatp.org, or you simply can follow our Instagram and Facebook pages as well. And if you have missed our previous webinars, do check out our YouTube channel as well. And we really appreciate if you could subscribe as well. Thank you so much, and have a great night.